fluids out, what medication the doctor might prescribe? Furosemide. So now what are the things that the nurse should be looking and be cautious about? That the patient don't get what? Electrolyte, the patient don't get hypokalemia. Perfect. So what lab values the nurse should be looking at? Potassium and sodium, most likely. All of them. But the ones that concern you the most is potassium, right? Because you don't want the patient to go into cardiac arrhythmias. Okay, so that's fluids overload. That's what you need to know. Dehydration. What do you know about dehydration? What is it? Patient not taking enough fluids for many reasons. Okay, how do you assess dehydration? Skin turgor, what else?
Sunken eyes.
Sunken eyes, what else? Urine output again, right?
You can see oils in the tongue.
Yes, very good. And what happened with the urine output with fluids overload?
You shouldn't have a lot because you're retaining it. You don't have very little.
So it's gonna be less than?
That's the reason.
There you go. That's what I want you to remember. Very good. What happened to the sodium with dehydration? Goes up. What happened with 1010 and 1030? All right. What is gastroenteritis? An inflammation in the GI tract due to a bacterial, viral, could be anything, right? Now, because of that, the patient may have vomiting, diarrhea. These gastroenteritis may put this patient at risk for fluids and electrolytes imbalance. If you know that the patient is having nausea, vomiting, diarrhea, 4 hours, that's okay. 8 hours, that's okay. The patient can drink oral fluids, right? 24 hours, 48 hours, that's a problem, right? Remember what I said when the patient is dehydration, what are the other signs and symptoms that these patients may have? Disoriented, right? Remember? Yes? So critical, you can have a diarrhea for 6 hours, you drink your fluids, but after a certain amount of hours, you need to compensate that. So what do you think we have to do for that patient? Oral fluids? They're not working. IV. Because can you imagine if his oral is not taking over to correct the problem, then what is the next step? Which one? Most likely 0.9, right? Just to begin with, and we'll see what happens. The doctor will give you the order. Perfect. So what happened with the NG2 and electrolyte imbalance? What's going on with that?
The suction.
What happened with the suction?
It can create, yeah, it'll eventually cause like potassium hypokalemia, and I guess it takes out suctions parts of the food, so the patient's not gonna absorb certain electrolytes from the food.
And also it's taking gastric content. So that patient might be at risk for metabolic
Acidosis.
alkalosis. Okay? Now, let's talk about metabolic alkalosis. You just have to remember what happened. Is my patient vomiting? Yes. Now, if I give you a number, what happened to the pH? Stay the same, or goes up, or goes down?
For alkalosis, it goes up.
And who is the other guy that's gonna go up and down? HCO3, right? It's gonna go up, it's gonna go down. So this is the thing that I want you to remember for metabolic alkalosis and metabolic acidosis. When the patient is having an acidosis, okay, the bicarbonate, the patient probably is having a lot of diarrhea, it's not the gastric content involved anymore. It's no gastric content in there. It's not coming through the mouth, right? So that is metabolic acidosis when we're talking about diarrhea.
Do we also have to know respiratory?
No, that's for next week.
Okay,
Well, on Thursday,
okay.
yeah. That I'm talking about cardiac and respiratory, okay? So now, what is hypokalemia? Anything low than 3.5. That's hypokalemia. So if the patient has risk or is having a hypokalemia, what do you suspect? What's the main problem? The heart. The heart will have what? Dysrhythmias. Perfect. The same thing with hyperkalemia. Anything above what? 5. Do you think this patient needs to be in the telefloor if a patient is having with all these problems? Yes, most likely. We need to monitor these patients, right? Now, if the patient is having too low potassium, you know the doctor is going to order what? Potassium treatment, right? To correct the problem. Maybe the patient also was taking diuretics for too long, and that discompensates the patient. Now all the electrolytes drops. Now this patient is going to be on potassium drip to put it back. Because we find out with the AEGs that this patient is having this problem. So hypervolemia, what are most likely the symptoms that the patient has hypervolemia? Remember, burns, diarrhea, vomiting, hypervolemia? What is hypervolemia? Retaining what?
Fluids.
Fluids. Are you guys okay this morning? Hypervolemia is retaining fluids. Remember what I said, maybe it's a kidney problem, or what about that hormone? Yes. Now, when we talk about hypovolemia, yes, let's talk about a patient who has a burn, right? Who has been losing a lot of fluids due to diarrhea and vomiting. What about hypovolemic shock? Remember that picture? We stop the guy on the floor with a knife in the chest. What's going on there? A lot of blood, a lot of fluids coming out of that body. So we need to replenish back with sodium chloride, hopefully with blood if we have it, so we can save that patient. What is hypovolemic shock? Well, everything is what? Declining. There's no proper tissue perfusion there. Patient is losing rapidly the blood. So what are the signs and symptoms of hypovolemia in regards to cardiac?
Have a weak pulse, but it's gonna be fast to compensate. So you're gonna have tachycardia with a weak pulse.
That's very descriptive. That's very important to know. That is not only high, it is elevated, but it's weak. Very good. So then it's gonna be, the patient is gonna be hypotensive, that's mean low blood pressure with a heart rate, elevated heart rate. That is with hypovolemia. With hypervolemia, it's gonna be what? Blood pressure is high and tachy. Where is that information? Right here in page 344 in ATI. All right, so let's talk about the difference in diets. Where is that in my ATI? I want you to know specific diets, right? And the diets that I want you to be aware, I don't know what page was that. I know it's in nutrition.
Nutrition is 213.
213, perfect. Refer back to what ATI have there for you guys. I want you to know 3 in particular, right? Cardiac, mechanical, liquid. soft liquid, you need to know those. If you're teaching a patient in cardiac, what you should be telling? No sodium and what else? Fat. Right? The patient has too much fat. He was eating too much pork every day. Cajachina every Christmas time. Christmas time was every week. My goodness. So now he has a high cholesterol. Remember my cholesterol levels? Triglycerides, HDL, LDL that I went over in class? Okay, so remember those numbers. And on top of that, my patient has a horrible diet that's eating a lot of fat and now eating a lot of sodium. So that is the horrible combination for that. What about clear liquid diet? What's going on? Anything that you can see through, and if you cannot see through, that's fine. For example, coffee. As long the coffee don't have what? Cream. Cream. You put cream, that's no longer. That's not longer.
And gelatin.
Yes, anything that you can kind of like see through. Something that is gonna change it, like cream, is you adding fat into that coffee. You adding fat into that tea. That's no longer. Oh, but it's tea, but no. No, you put cream. A little bit doesn't matter. Already have cream. Okay? All right, so let's talk about CKD. What is CKD? Kidney what? No. CKD.
Chronic kidney disease.
Chronic kidney disease. You were very close there. Chronic kidney disease. Remember these stages? Well, you need to know these stages. 90, less than 60, stage 3, stage 4, stage 5, ready for, hopefully, kidney transplant, if they can find it, right? What happens when a patient has CKD and is stage 4? What do you see in that patient? If the kidneys are not working, what happens?
You're not gonna have urinary output.
Urinary output will be less. What else? They're retaining fluids. Yeah. You will see this patient with a lot of edema here and there, problem, puffy face, because they're retaining that fluid. What happened to the heart? This patient is gonna have cardiac problems, because remember the kidneys and the heart, they work together. So when there is a problem with cardiac, might be a problem with the kidneys as well. So that's why patients who suffer from high blood pressure for a long time, guess what? They want to have kidney problems. I don't know if you all know that, so I want you to know that now. Patients who suffer from high blood pressure, that we don't treat the blood pressure, this patient is going to damage their kidneys. So that's why the nurses, the doctor, sir, you need to take your medication. You need to take your medication, because a patient who has high blood pressure for too long, the kidneys are going to get damaged. So now you understand why we have to kind of take your meds. You want to damage your kidneys. Heart and kidneys, they are like brothers and sisters right there. Okay? All right, so let's talk about diabetes type 1 and 2. You know the difference. You know this from patho. Type 1 is insulin dependent. Type 2 is what? Resistant is what? Lifestyles, right? Oh, you don't exercise, too much cajachina, too much pork, too much this. So you could fix it. You could delay that, and you maybe, but when you already have diabetes, how do you know the patient has diabetes? Oh, let's go back to my testing. Glucose testing. You need to know the glucose testing. Fasting glucose should be, you tell me.
7,200.
Perfect. Anything higher than that, 110, 115, 120, 126, you need to confirm that with what test?
A1C.
A1C. So tell me the ranges for the A1C. What is diabetes? 6.5 and above. What is pre-diabetes? Between 5.8 and 6.4. And no diabetes at all is less than? Less than 5.8. Beautiful. You need to know that. You need to know fasting glucose. Now, Let's put back my table, and you already have that table of the insulin, okay? What do you need to know about the table? Peak time, what else? Duration,
Onset.
and the onset. You will have one or two questions again, but that's easy peasy for you because you already know the table. How many different type of insulin we have? We have the MPH, that is the cloudy. We have the regular, that is the only one we can give IV push. And that IV push maybe it's an emergency, maybe that's the reason we have to give it IV push. And the long acting is working throughout 24 hours. You educate your patient about eating a little bit in between hours, so the glucose doesn't drop too low. Okay. So now, it's nothing that I can tell you here where I talk about the electrolytes that you just need to know. The sodium, potassium, chloride, magnesium, calcium, BUN, creatinine levels. You need to know, these are the labs that you need to know for this test. BUN, creatinine levels, urinalysis, BMP, CMP, right? Troponins, what are the troponins? Those are the cardiac enzymes to check for what? An MI, if the patient has any injury in the heart. Yeah, so that's to confirm that your patient actually have an MI. Why you need to know that? Hey, we're talking about electrolytes, we're talking about potassium, we're talking about damage in the heart. So if the patient complains, I have a pain, we want to put this patient in EKG and we want to draw what lab? Troponin. We call that cardiac enzymes. Okay? BUN and creatinine, for what?
The kidneys.
Kidneys. Yes, remember? And you get them from the CMP. What do you get from the BMP, basic metabolic panel?
Electrolytes.
Good.
Which one was for magnesium? That it was not magnesium. Do you think you could
Magnesium.
Yes, you said that we couldn't get magnesium.
Yes, that's a separate test. A separate test that you have to get by yourself. Yes. And I really want you to learn calcium levels. Calcium levels. What are the levels for calcium? 9 to 10. Please take a look at your future nurses. That API breakdown, 9 to 10.5. 9 to 10.5. Page 350 in API. And API. Take a look of what happened with hypo and hypercalcemia. Right there for you, and I talk about it. Bone pain, Paget's disease, bones are fragile, ready to break. When and why that happened, it's right there. I know, and these are one of the things that when I do the test, I want to look Taylor and I want to look ATI, and that's what I always go back. I will never give you a number that is going to be too close to what I have give you. All right? So I want to refer you always to the ATI because these are the updated numbers that I should have done it there, but I didn't because of the Taylor, because the Taylor has some numbers that are a little bit off. They're not off, guys. When it comes to lab, the laboratory, they always have a little bit of discrepancy between numbers. And it's not because they're bad or wrong, it's just because the way they work. What we need to know, at least between this number and this number, we're working with these two numbers. So that's what we need. And that's why I will never give you a number right there, okay? So take a look at the signs and symptoms of hypocalcemia, hypercalcemia, and hypomagnesemia, which is low magnesium or high magnesium, which is in page 352. Why? Because if the patient has GI problems, thiazide, loop diuretics, malnutrition, okay, it's right there. Chronic kidney disease, with hypermagnesium. That means the kidneys are not working and the patient is retaining that. So the patient will have hypermagnesium, too much magnesium. Okay, you see there, 2.1. Anything greater than 2.1 is to be considered hypermagnesium. So this ATI is breaking down the labs and signs and symptoms. And take a look of what happened with hypocalcemia. Remember about the signs of the tapping and the facial nerve and tweaking? How do you call that one? 351. Yes. And that is hypo or hyper? Hypocalcemia. Beautiful. I talk about that in lecture, okay? Who went to the boot camp for electrolytes?
There's one today. There's one today.
Or the one that was last week? They talk about this, hypocalcemia?
Yeah, it was okay. It was just some of her stuff on the PowerPoint wasn't right, like it didn't match up with the textbook and with like Professor Stevens' notes that I had from before. So I just followed the textbook as well. Yeah. Like, yeah, some of the signs and, like, a couple of the signs and symptoms weren't right.
No.
No, it was like the opposite. If something said hyper reflexive in the book and in Professor Stevens' notes, hers like it's something said hypo reflexive, and so yeah, I just stopped following that. But the practice questions were very good.
Good.
Yeah.
All right, so that's what you need to do for this. And take a look what ATI I have here for hypo and hyper. Because you want to have question about signs and symptoms. Remember I told you this quiz is a lot about signs and symptoms. What do you see in hypo? What do you see in hyper? So here, ATI has break down this information beautiful for you, okay? Don't let it go. What do you know about the urinalysis? Let me put you back in urinalysis. You need to know urinalysis for the quiz. Everything should be negative, right? And regards the results. However, if the patient has a little bit of blood, should be no more than 2, right? And what else? The pH of urine is what? Don't confuse the pH of urine with the pH of the blood. Good. So anything else, ketones, protein, should be negative, right? Now, if you suspect of a kidney infection, you need to assess the urine. You want to be assessing for W, disease. That's mean white blood cells in the urine, that's a presence of an infection. Okay. What about if the patient has ketones? What are you suspecting? A patient who might be what? Who? Diabetes. Or glucose as well. So keep that in mind. Dehydration in the urine. You want to be looking at specific gravity. Isn't it? 1010, 1030. Okay, good. I know, it's a lot of values, it's a lot of things. Yes, lab values, signs and symptoms. And ATI has break down this information so nicely for you guys because they put you hypokalemia, signs and symptoms, risk factors. What is it that you have to look and understanding your lab values? So my questions is gonna be, okay, there is a patient who possibly probably is having hypokalemia. What are the signs and symptoms you wanna be looking at? Se le acabo de hablar. 1, 2.
Oh,
Yeah, okay.
So if you know the signs and symptoms, you will not miss it. Okay? Now, one thing that I also told you about my fluids, all I want you to remember is isotonic, hypertonic, and what? Hypotonic. Example of isotonic will be 0.9. Hypertonic, what happened to the cell? Shrink. Give me an example of solutions. At least one.
45? Yes.
Okay, review that information, okay? What happened when the nurse set it up the pump bad? Maybe it's giving literally the infusion too fast. Think about 1,000 ml of sodium chloride should be given in 12 hours, right? But she did the math wrong. And she's gonna give 1,000 ml within 1 hour, 2 hours. What's gonna happen to that patient? Hypervolemia. Too much fluid, too much, too fast. Okay? So now this patient is gonna have cardiac signs and symptoms. What symptoms are those? High blood pressure and tachy. Beautiful. Got it. Okay. So, oh, something is wrong. Why my patient? Oh my God, my mom. Stop the pump. Right? Hopefully. Stop the pump. Hopefully. Okay. So that's it. Any questions? I'm open to questions here because I know it's electrolyte and kidney disease and insulin, nutrition. No questions. I went a little bit fast for me to have the opportunity to answer questions. No? You're good? Not necessarily. Yes. Not necessarily, that's what I'm saying. Could be every patient in future, yeah.
For the section that's metabolic alkalosis, are you gonna put like the pH number, then we need to decide what is?
Yes, very straightforward. Yeah, know your pH and know your bicarbonate if it's there, what's going on. If it's acidosis, the patient is having a diarrhea. Alkalosis, think about the stomach gastric content. It's getting discompensated because the gastric content is, patient is
I
losing
think
it.
of emesis, when you're throwing up, then
Yeah.
you're getting rid of all your acid.
Yeah. You don't have gastric content in the rectum. You don't, right? Good. What else? Know your values, ladies and gentlemen. The values for the lab is what is going to save you from trouble. Okay? Know your urinalysis results. Know all the tests that I told you, CMP, BMP, creatinine, BUN, glucose levels, so you can answer my question for diabetes, which is straightforward because you already know diabetes. Okay? What is CKD? You already know the stages and what to do. Signs and symptoms, pretty much. You know when the patient is retaining fluids. Okay, what's going on with the kidneys? How do I find out there's a problem? Let me draw a CMP. What is the CMP you want to be looking at? The UN and creatinine levels. What is you teaching for your patient? I forgot to mention that. With elevated creatinine, what is the diet that this patient needs to be on? A renal diet. We call it renal diet, right? It's not in the ATI, but I'm telling you, a renal diet. What that means? Remember what I said about at the restaurant? What is that restaurant? Texas de Brazil? What happened with me? What happened with these bodybuilders?
They eat too much protein.
Protein, right? So you want to teach your patient about what? No protein at all. Because your creatinine levels is already too high. You're blowing your kidneys. Yeah. So what is MPO? Nothing by mouth. Why the patient might be nothing by mouth? Surgery, right? To avoid possible risk for aspiration. Now, if the patient has MPO orders, the patient is coming back from surgery. This patient shouldn't be on regular diet right away, right? So we want to start with probably clear liquid diet, kind of. Yeah. Especially if they come in with general anesthesia procedure. You know what happened with the peristalsis with general anesthesia, right? They kind of like slow down. They're hypoactive, which is less than 5 bowel movement per minute. So So you know the patient is hypoactive. So you know it's a process. Good. Any questions? You're being very quiet this morning. Good? Right.
What should be the
The what?
LDL?
LDL. Okay, so when we talk about cholesterol, the lipid panel, we have total cholesterol should be less than 200. And that was a homework. Remember I told you, there is the homework that you need to look for these values. Triglycerides, less than 150. HDL above what? 40s. And LDL, yes. More or less?
Less.
Yeah. Which is the bad cholesterol. We call it bad cholesterol, right? And we want high the good cholesterol, which is the HDL, should be more than 40 because that's the one is gonna bring the bad guy down. Okay? And if that patient is having that problem, what type of diet this patient needs to be on? Well, what's the name of the diet? Cardiac diet. We call it like that, cardiac diet, clear liquid diet, renal diet, mechanical diet. Okay?
What is the mechanical?
Oh, I don't know. Where's that in ATL? Who's the patient that has that problem that needs to be a mechanical diet? Let's look it up. Yes, to avoid possible problems with dysphagia and not dysphagia, aspiration. That's what we're saying. Yeah. Very good. No more questions? All right. Did everybody sign my attendance? Just when you have a chance, just